Hey folks, do you know that the management of odontogenic keratocyst, especially in children, is quite controversial? Yeah, whether to do aggressive treatment or to go with the conventional one, yeah, it is still a subject of debate. Also, the age group of the odontogenic keratocyst, which is the second and third decade of life. But today is your opportunity to see such odontogenic keratocyst in a 12-year-old female patient. Also, you will see various treatment modalities and different diagnostic procedure to go with it. Hi, I am Dr. Neha, your maxillofacial physician and radiologist. I talk about my interesting cases in this series of video, and today is the case of odontogenic keratocyst in a 12-year-old female patient, which is a rare one. And I will also talk about some theories regarding odontogenic keratocyst in this entire video, so watch it till end. So this is my patient who is 12-year-old female. Her parents reported to the clinic with the chief complaint of swelling in the lower left back region of the jaw since 2 months.
Here you could see both the extraoral and intraoral view of the swelling.
Patient reported that her milk tooth, which was not decayed, got exfoliated 3 months back. 15 to 20 days after the exfoliation, she started noticing the swelling in the same region. The swelling was associated with mild intensity pain, which was only on provocation. There was no sign of fever or chills. There was no sign of paresthesia, pus discharge in or around the swelling. On extraoral examination, we found that there was a lymphadenopathy associated with 2 left submandibular lymph node. On intraoral examination with inspection and palpation, we found that the swelling was diffuse, normal mucosa colored. There was no sign of bleeding or any sinus formation in and around the swelling. On palpation, we found that the swelling was hard and tender with no eggshell crackling sound. Now remember that if there is a break in the cortical plate, you will find the eggshell crackling sound during your palpation procedure. Now, taking into account the differential diagnosis of the lesions occurring in that region, like dentigerous cyst or ameloblastoma, we conducted certain radiological investigations like IOPA, intraoral perioapical radiograph, to see the displacement of the teeth or root resorption. We also conducted occlusal radiograph to see the integrity of the cortical plates. We also conducted an orthopentamogram to see whether it is associated with the Golling-Gott syndrome, because in the Golling-Gott syndrome, you will find multiple OKCs in the upper and the lower jaw.
So here in the IOPA, you could appreciate the displacement of the teeth. In this occlusal radiograph, you could see the buccal expansion of the cyst with intact cortical plates. The OPG showing no multiple cystic lesion in upper and lower jaw. And of course the CBCT for the exact anatomy for the surgical procedure, and it also helps in differentiating dentigerous cyst from the keratocyst.
We also conducted a fine needle aspiration cytology, which revealed a cheesy keratin-like material. Now, cheesy keratin-like material is again an indicator of odontogenic keratocyst. So now coming to the surgical management, which is quite controversial, as said before, but there are certain factors which determines whether to go for the aggressive one or the conventional treatment. Factors like size and site of the lesion, the recurrent status, the destruction of the cortical plates, and of course the histological variant of odontogenic keratocyst. Now see, although the aggressive treatment like resection has a low recurrence rate, it can lead to deformity of jaw in a younger age group, and this can lead to the serious psychological outcome in an adolescent. So it is important to give priority to the reduction of complications as much as possible. And then talking about the conservative approaches like enucleation alone, enucleation along with the adjuvant therapies like peripheral osteotomy or cornoid solutions, cryotherapy, it can be used, but it has certain limitations like recurrences.
So keeping in mind the clinical, radiological and cytological aspect of examination, we conducted marsupialization of the cyst with the preservation of the tooth. We also provided patient with an obturator to avoid infection, and demonstration of the placement of obturator is important in the pediatric patients. So this is the picture taken 10 days after the surgery, where patient seems to be quite happy.
So the takeaway note from this case report is that the aggressive manipulation of OKCs in children can endanger the eruption process and the development of the involved jaw. So a conservative approach should be considered in them. However, aggressive treatment should be considered in cases where there is recurrences even after enucleation followed by adjuvant therapy, or cases in where there is recurrences even after marsupialization followed by enucleation with adjuvant therapy, or in cases where there are multiple OKCs, whether it is syndromic or non-syndromic, or in the cases where OKC shows aggressive clinical behavior. So that's it, folks. It was all about my case, which was odontogenic keratocyst. If you want to see more such interesting cases, do visit my channel. I will meet you in my next video. Till then, you take care of yourself.